issues. How long should an implant be? What length is important or not? So a lot of things. We start with the 80s. So in the 80s, these are one of the first studies, we are going to see a lot of them. It was completely, let's say, normal to have bone resorption around implants. This is a systematic review, and it was common to have 2 millimeters of bone loss, so marginal bone loss around our implants the first year, and it was normal to lose 0.2 millimeters. It means 1 millimeter every 5 years. It was common to have bone resorption, and it was the beginning of implantology. And again in 2000, so after 15 years around, not a lot of years ago, Steve Tarnow, which is a professor of Columbia University, another systematic review, it was normal first year around 2 implants bone loss. And again, 1.8. This was a congress in Pisa, our city in Italy. There were a lot of professors from all around the world, and still, so around 15 years ago, was still normal to have 2 millimeters of bone resorption. So again, 1 millimeter every 5 years, 2 millimeters the first year. Another systematic review, so it's normal to have bone resorption around implants. And other studies. So from the beginning of implantology to around 10 years ago, it was expected to have bone resorption around our implants to the first thread, so of the implant, the first thread, so 1 millimeter, 2 millimeters. But today, of course, this is not acceptable anymore. So it's not acceptable because today we have knowledge, we know more about implants and also more about how to place an implant, what to look at when we place an implant. Today we can regenerate also bone, and we know about biology, biomechanics, in order to decide where I should put my implant. So, because what's the main problem? What happens if we have bone resorption to the actual implant surface? So what happens if we lose bone up to this area, which is rough, because it is etched? The problem today is that we are going to have periimplantitis. And if we have a contamination with bacteria of the rough surface of our implants, it's almost impossible to remove all bacteria. So there's a high risk that it can come again, periimplantitis. So this is a prospective cohort study that was analyzing a lot of patients. And if during the first year there was a bone loss of 0.5 millimeters to 1 millimeter, and there were additional risks like smoking, alcohol, so of course there was a high risk of periimplantitis. So in these kinds of patients especially, we should be able to have always bone around our implants, because the degree of periimplantitis, the degree of bone resorption is going to go faster. Another study. Now here we had 2 groups. They were analyzing if there was a significant difference between implants with enough bone and implants with bone resorption, bone reconstruction, so sinus splits. So even if there was not enough bone and bone was built up with an internal sinus split, external sinus split, there was still the same amount of periimplantitis. So it doesn't depend if you increase the amount of bone, the vertical bone, you still have risk of periimplantitis if we don't consider how much bone we need to have around the cortical area of the implant. So it doesn't matter how long is our implant, it doesn't matter. The important area is the 3 millimeters around the top of the implant, so the 3 millimeters close to soft tissue. So solution, in order to avoid bone resorption, we need to have knowledge about what kind of implant to use and criteria. When should I regenerate bone? When should I regenerate soft tissue? We have seen already during this week with other professors, we know a lot about that, so we are going to recap a lot of information, a lot of features. So we have to take into account biology, mechanics, and function. We have 2 biological variables. The first is bone, and the second is soft tissue. So we should have enough soft tissue around our implants. A very healthy soft tissue around an implant. Now, this professor is from Lithuania, Tomas Linkevičius. He's very famous. He has been studying for years soft tissue, And he analyzed a lot of differences between biotypes of people. So thin biotype with 1 millimeter of soft tissue, medium biotype 2-3 millimeters, and thick biotype. So there are people who have 4 millimeters on average of soft tissue height, and others they have 1 or 2. And he noticed that if there was a patient with 2 millimeters or less of soft tissue around our implant, there was a high risk of periimplantitis and of bone resorption after the first year after loading. It means after 3 or 4 months or 2 months, it depends when you place a crown on top of the implant, you are going to have a high risk of bone resorption and periimplantitis. So, how should we thick our implant, our soft tissue, sorry. So, first of all, it depends also on where there is the connection, because here you have 2 different implants, and in this study, we have seen that if the abutment implant connection, so the gap between the abutment and the implant, is 2 millimeters over bone level, like in a tissue level implant, the risk of bone resorption and periimplantitis is very, very low compared to bone level. And that's why, because the connection between the implant and the abutment is far from the bone, which is the risk area. So, soft tissue thickness required to protect underlying bone. This was a study with 4 millimeters, patient with 4 millimeters soft tissue. So, here we had 4 millimeters and there 2 millimeters. Of course, patient with 4 millimeters implant soft tissue had next to nothing bone resorption, because it was thick enough, this soft tissue, to prevent periimplantitis, of course with the correct hygiene. With 2 millimeters, there was always bone resorption around the implants. So in this study, 3 kinds of people: thin biotype 2 millimeter or less, 2.5, the medium, and the thick one 3 millimeters. Significantly less bone loss, of course, around bone implants, bone level implants with thick mucosa of 3 millimeters. So we already know that we need to have 3 millimeters of soft tissue around our implant. Soft tissue has to be 3 millimeters in order to prevent the high risk of periimplantitis. And of course, we have to teach our patient about oral hygiene and so on. What about bone? How much bone should we have around our implant? Well, we need 2 millimeters, 1.5, 2 millimeters even better of bone all around our implant. And especially if you have an implant close to another, you need 3 millimeters, because implants, they don't have periodontal ligament. So they cannot move and the bone cannot regenerate at the same rate of bone around it. So we need 2 millimeters of bone around an implant close to teeth, 2 millimeters also buccally on the lingual palatinal side, and 3 millimeters between one implant and the other. So we already know that if we are going to place an implant, we will have to measure how many millimeters of bone we have. If we don't have 2 millimeters buccally, 2 millimeters on the lingual side or palatinal side, plus the diameter of our implant. So if we don't have, for example, the implant is 4 millimeters, we need at least 8 millimeters, 7-8 millimeters of bone, buccally, palatal, and mesiodistal. If we don't have enough bone, we already know that there's a high risk of bone resorption in the future. So 2 millimeters of bone around our implant and 3 between an implant and the other. So we should take into consideration also factors of crestal bone loss. There's also other factors that can affect our bone around the implants, which is the microgap, so the space between the implant and the abutment. And of course, as we already said, vertical soft tissue. So we are going to see also what can we do in order to increase the amount of millimeters we need around of bone and soft tissue around our implant. This is the gap. We already talked a lot about that during this week. So this space is very critical because we are going to see also more stable connection where this space is like, it is almost nothing, but in the internal connection implants, conical implants, we are going to have a gap. And so we are going to have a high risk of periimplantitis because here we are always going to have a micro movement of the abutment, and we're going always to have space. And where you have space, you have bacteria. So, platform switch, as we're going to talk later on, is one of the best connection because we move this gap from the side of the implant on the platform edge, so on the top of the implant. So this gap is far from bone. And we're going to see also how much should be, how many micron should be this platform switch in order to work. So platform switch implant, they reduce more resorption around our implant. So how to manage, how to increase bone, when to increase bone, when to increase soft tissue, and how to do it. We have different kinds of things we can do. When we have enough bone height, so we have a lot of bone vertically, but for example, our bone is not so big. We have a triangular crest, for example. We can flatter crestal bone. We can place an implant subcrestally. If we don't have enough bone, there are also other techniques with bone graft, soft tissue grafts. We're going to see all of them. So, let's say we have enough bone height, but our bone is triangular. So on top, we don't have enough thickness. So we can reduce the triangular area in order to increase the amount of millimeter we have buccally and lingually, and place our implant. So reduce the height in order to have 2 millimeters, and then 2 next to the other tooth, or 2 to the other, or 3 to another implant. Another technique is to place an implant subcrestally. Now, when we do the first surgery, even if we have enough bone, enough soft tissue, the best connection, because of the surgery, we are going to expect bone resorption a little bit because of the surgery. That's why we say we should place an implant 1 millimeter lower to the crestal bone, but if you have enough space, even 2 millimeters is even better, because you can expect anyway bone resorption. That's because of the contamination during the surgery, because we open up lab. So even if we have everything sterile, we work with sterile instruments, sterile tools, we are sterile gloves, everything, we are going to have bacterial contamination anyway. So it's normal to have a little bit of bone resorption. That's why we can even place an implant 1 or even 2 millimeters if you have enough space. We can even augment soft tissue. We are going to see, we have already seen with the professor before a technique, how to submerge in the box. But we are going to see also that. So as I said, one technique that Linkevicius studied was to place immediately on top of the implant a healing abutment and to put stitches on top of it. So soft tissue, if soft tissue were not 2-3 millimeters, which is ideal, 2.5-3 millimeters, placing an implant and a healing abutment and suturing on top of it was enough to increase the volume of soft tissue, even if, because of the surgery, there was still a little bit of bone resorption. So a technique you could use in order to increase the amount of soft tissue is to immediately place an immediate healing abutment and put stitches on top of it, like the professor this morning showed. This is a technique that we use, and the professor this morning showed also. Basically, temple is a screw and a membrane, so bone reconstruction, vertical bone reconstruction. We don't place the implant in this case, we build it up, and then in a second surgery, we can place an implant. We measure bone. So if we have enough bone, we can flatter crest. If our thickness is not enough, we can regenerate bone. And for soft tissue, we can even use grafts, as we are going to see. So this is also a technique to increase the height of our implant. Or if we have connective tissue grafts. So we can do like this. This is an osteostructive implant. So we place an implant. We can even not place the bone. New studies shows that if you have buccal bone here, you have a gap, blood is coming to the gap. If you seal very well with a graft, or if you suture very well on top of the implant, here you are going to have new bone. you should place an implant. This is a mistake. It should be a little bit deeper. You should have 1 millimeter here of bone, because you are going to have a little bit of bone resorption after the surgery. So we place our bone, we place a graft if we want to increase connective tissue grafts or even allograft, xenograft, in order to increase soft tissue volume, and then we wait. And then we should have enough bone tissue, enough soft tissue. This is an example, so this is a post-extractive implant. Something very important is that you see this is an hexagon. Ideally, in order to distribute stress, the crown stress, when this implant has a crown, stress and strength of this implant in the best way, the surface of the hexagon should be parallel to the buccal. In this way, on the angle of the hexagon, when your implant has a crown on top and so the patient is eating, forces are going to be distributed through the angles, and they are not going to go directly on the surface of the buccal bone. So ideally, the best should be, as we said, to regenerate bone or place a graft here in order to cover, because if you have bone here and you have buccal bone here, you're going to have your bone. And if you can, the best is if you place an hexagon implant. This is an external connection, so it's not the best. We're going to talk about that after. It should be the best to place this surface parallel to the buccal for force distribution, to have a better spreading of force. So we have allograft, this is from other humans, and is a scaffold of blood vessels. You have to hydrate that before you use it with salt water, for example, with salt water, and then you're going to place, as we said, here. Or even you can place on top of the implant. We are going to see after, even on top of the implant, and put stitches if you see that you don't have enough soft tissue. Remember, soft tissue normally should be 2.53 millimeters. You have around 1 millimeter of epithelium, and then around 2 millimeters of connective tissue. So what you want is to increase the amount of connective tissue in order to make it thick and to bring the epithelium and the sulcus far from our bone. So you can even do like this. If you don't see enough soft tissue, you take a graft, you put stitches on top of the implant, and you put stitches on also in gums, and so you wait. This is the not submerged technique. It means that you can even use a graft. You make a hole in the middle, and you place a healing abutment. So you increase the quantity of soft tissue. You can even do like this. So it's the same of the first. The difference is that you immediately place also healing abutments, like this. Xenograft also. This is from Biotis. So xenograft is recommended. You can increase soft tissue up to 2-3 millimeters. So as bone thickness approaches 2 millimeters, so just to recap, with 2 millimeters of bone around our implant, significantly less risk of bone resorption. In systematic review, you need 2 millimeters of bone around your implant. If the initial mucosa thickness is more than 2 millimeters, there is significantly less crystal bone change. So again, 2 millimeters of bone and 2-3 millimeters of soft tissue. Buccal bone thickness more than 2 millimeters associated with minimal marginal bone loss. Critical buccal bone wall thickness of 1.5. So again, 2 millimeters, I think it's clear, right? So here you see, here you have a lot of bone, and you're not going to have bone resorption. Here you have close to nothing bone, and here you have mucosa on top of the implant. This surface is full of bacteria, so you're going to have a high risk of periimplantitis there. The bone is not protecting the implant, and the rough surface of the implant is going to be contaminated by bacteria. So again, right space. For example, this is a bicon. What do you think? Here is perfect, but here, are you going to have bone resorption, a high risk of bone resorption? Yes or yes? of course you're going to have a bone resorption because it was better to place this implant a little bit more palatine. So now we're going to